Good day everyone, welcome to my channel Lively Life Snippets. Wishing you living your life in the most lively way. This is the continuation from Ready to Beat Malaria CME session because I received many queries. Without further ado, let's start with the first question.
The first question that I received is the life cycle of Anopheles mosquitoes same as other species of mosquitoes. Anopheles mosquitoes, like all other mosquitoes, undergo 4 distinct stages, which are eggs, larva, pupa and adult. There are slight differences in terms of eggs and larva stage. Anopheles mosquitoes lay eggs singly on water surface while other mosquitoes' eggs are stuck together in rafts. Besides, the larvae of Anopheles mosquitoes do not have a siphon and lie parallel to the water surface to get a supply of oxygen through a breathing opening, but the larvae of other mosquitoes have siphon tubes for breathing and hang upside down from the water surface. Some larvae attach to plants to obtain their air supply.
The second question is what other types of medicines may harm patients with G6PD deficiency, except primaquine. Drugs with definite risks include but not limited to primaquine, methylthioninium chloride, nitrofurantoin and quinolones, sulfonamides, dapsone and prilocaine. On the other hand, some examples of drugs with possible risks include aspirin, chloroquine, quinine, vitamin K analogues and sulfonylureas. The extent of hemolysis may vary across individuals, due to genetic heterogeneity. Despite this, the extent of hemolysis is dose-dependent. Advise patient to inform doctors, dentists and pharmacists before receiving any treatment.
The third question is for patient with impaired kidney function or acute renal failure due to severe malaria. Which type of antimalarial need dose adjustments? Clindamycin, primaquine and doxycycline do not require dose adjustment for creatinine clearance less than 50 ml per minute. If patient's creatinine clearance levels are less than 10 ml per minute, the recommended dose frequency of quinine is odd, while if the creatinine clearance levels are between 10 ml per minute to 50 ml per minute, quinine can be given BD or TEADS. No dose modification of intravenous quinine for first 48 hours even if renal insufficiency is present. After 48 hours, halve the dose in presence of renal failure.
The dose of chloroquine should be halved of normal dose if patient's creatinine clearance levels are less than 10 ml per minute. No dose adjustment needed for Riamit and mefloquine. For sulfadoxine pyrimethamine or fansidar, no detailed instruction on renal dosage adjustment references. It should be given with caution. No dose adjustment needed for artesunate. For malarone, which contains atovaquone and proguanil. No dose adjustment needed for atovaquone, but use proguanil with caution. If patient's creatinine clearance levels are less than 10 ml per minute, proguanil maximum dose is 50 mg weekly. If patient's creatinine clearance levels are between 10 ml per minute to 20 ml per minute, proguanil should be dosed 50 mg every 48 hours. If the patient's creatinine levels are 20 ml per minute to less than 60 ml per minute, proguanil dose can be up to 100 mg daily. However, malarone is contraindicated for prophylaxis of P. falciparum malaria in patients with severe renal impairment with creatinine clearance less 30 ml per minute.
The fourth question is, can artesunate mefloquine-coated tablet be crushed for children who are unable to swallow? For children who are unable to swallow tablets, the tablets, which are small, 6.0 mm diameter for children less than 6 years old, and 9.6 mm for children 6 years old and above, should be placed on a spoon with water and allowed to disintegrate before oral administration.
Artesunate mefloquine is depended on both age and body weight of children. The fifth question is for overweight children or adults. Which parameter should be used? In patients at the extremes of weight for the corresponding age, such as in cases of malnutrition and obesity, the dose should be adjusted according to the weight of the patient. Target dose for each drug is 4 mg per kilogram for artesunate and 8 mg per kilogram for mefloquine, corresponding to a total dose of 12 mg per kilogram and 24 mg per kilogram, respectively.
Let's use a sample case to illustrate this. A 7-year-old girl with 30 kilograms will need 120 milligrams artesunate and 240 milligrams mefloquine per dose. The figures are obtained by multiplying target dose with 30 kilograms body weight. 1 tablet of artesunate mefloquine with strength of 100 and 220 and half tablet of artesunate mefloquine with strength of 25 and 55 odd for 3 days is recommended.
The sixth question is what is the maximum dose for quinine, especially for patients with larger body size? The answer is all doses below are given for 1 week in 2 to 3 divided doses.
The seventh question is how to dilute and administer intravenous artesunate. To activate the drug, bicarbonate is needed to be reconstituted together with artesunate immediately before use. After injection of bicarbonate ampoule, shake until dissolved, and the solution will be cloudy. In 2-minute time, the reconstituted solution must clear. If not, discard the product. After reconstitution, the next step is dilution with saline solution or dextrose 5%. Please note that water for injection is not an appropriate diluent. For intravenous use, inject 5 ml of saline, while for intramuscular use, inject 2 ml of saline into the reconstituted solution. Now, the artesunate solution is ready for use. How to administer artesunate solution? For intravenous route, it should be injected by slow bolus, 3 to 4 ml per minute. For intramuscular route, the solution need to be injected slowly. Spread the doses of more than 2 ml over different sites for babies and 5 ml for adults.
The eighth question is what is the suitable chemoprophylaxis for children? For kids less than 8 years old or less than 25 kg doxycycline was contraindicated. For Malarone, children less than 5 kg should not be prescribed. Lariam is not indicated for kids less than 6 months old because the safety and effectiveness not established. For children between 6 kg to 20 kg should be used with caution due to limited experience. Otherwise, these agents can be used in older and heavier kids.
The ninth question is what is the presumptive treatment for Plasmodium knowlesi infection? 3 days regime for suspected P. knowlesi infection cases in high-risk areas. Patient present with fever more than 3 days with chills and rigors but awaiting result of blood film for malarial parasites slides. Give chloroquine with doses as shown in the table in the bottom right-hand side depending on age. Primaquine should not be given. Oral chloroquine 10 mg base per kilogram, maximum dose of 600 mg immediately then, 5 mg base per kilogram, maximum dose of 300 mg 6 hours later, day 2 and 3.
Question number 10 is a scenario question about management. If the patient has been started on Ryamet for suspected malaria while waiting for blood film results. 3 negative results are collected but the patient is still having high fever. Should the Ryamet tablets being stopped immediately or complete the course before alternative diagnosis is being found? Where the blood film is negative, at least 2 further films should be obtained over the subsequent 48 hours, before excluding the diagnosis. Be aware that an individual can have malaria despite a negative film. This is particularly the case in pregnancy where parasite biomass can be sequestered in the placenta. Seek expert help early if concerned. If a patient deteriorates whilst taking Ryamet, alternative treatment for malaria should be started without delay. In such cases, monitoring of the ECG is recommended and steps should be taken to correct any electrolyte disturbances. The long elimination half-life of lumefantrine must be taken into account when administering quinine in patients previously treated with Ryamet. If quinine is given after Ryamet, close monitoring of the ECG is advised. If Ryamet is given after mefloquine, close monitoring of food intake is advised.
Question number 11 is can rapid diagnostic tests, RDTs, being used for diagnosis? Rapid diagnostic tests, RDTs, which detect parasite antigens are available and, being dipstick-based investigations, are easier to use for staff without microscopy training. They have less waiting time and indirect costs, but have been relatively more expensive. The World Health Organization, WHO, currently recommends either RDTs or microscopy confirmation before treatment.
Please note that any content of this video does not substitute professional medical advices. If you have any health issues, please speak to your doctor and healthcare team.
Thank you for watching Lively Life Snippets. Comment below on what type of content you would like to see from my channel in future. If you like my videos, hit the like and share button. Don't forget to subscribe, and see you all in the next episode.